All right, so we're going to go over chapter 12 today. This is self-feeding, swallowing, and communication. Oh, it worked, and then it went away. All right, cool. All right, so you should have read chapter 12 before class. I'm assuming everybody did. Let's talk about self-feeding impairments. Different impairments are going to affect how somebody's going to be able to feed themselves, how they're going to be able to swallow. There's a lot that goes into self-feeding when you really break it down. Physical impairments, like if they have diminished strength, something very simple that sounds, like even some of the weakest people can bring a spoon to their mouth. No, that's not true. Because they're fighting against gravity, they have to bring the weight of their arm, then it's the weight of the utensil and the weight of the food. It doesn't sound like a lot to us because we're used to it. But you would be surprised how many people can't simply lift a utensil to their mouth, and how we have to adapt it because eating, regardless, has to happen. If they have limited range of motion, whether it be in their hand, wrist, forearm, elbow, shoulder, whichever it be, if they have poor core strength, they're not able to, sit up, or poor tone, bad coordination, all these things go into it. Why would sensation be a bad one for self-feeding? If you have decreased sensation.
You don't know if you're dropping like soup on you or food.
Especially if it's like a hot and cold impairment. You don't know if you're burning your tongue. You don't know if something's too hot. Grip is probably the biggest one that we treat in OT as far as physical impairments go in self-feeding. That's where, the built-up utensils, things like that we use are extremely common. Arthritis is the biggest cause of that. As far as visual impairments go, if they have poor depth perception, does anybody remember what depth perception is? Or can you give me an example of it? What?
Like the distance between lifting the food up to your mouth.
Not exactly. So your depth perception would be like if I'm looking here, I can tell that you are different than your water bottle. It's not one like you're further back than your water bottle is. Your water bottle is closer to me. That's depth perception. It's the depth of, I like to think of it as the depth of the picture that you're seeing. So making it 3D. Scanning. Why would that be an issue? Visual scanning.
If you don't have like a visual field, you're making sure you see everything.
Yeah, if somebody has that left side neglect and they either aren't seeing out of their left eye or they don't pay any attention to anything out of their left eye, they might even miss half of the meal. It might seem kind of strange, but literally like half a plate or a third of a plate will be completely untouched, and they feel like they ate the entire plate of food, but a third or whatever of the plate is not being eaten. Visual field, kind of the same thing. If your visual field is off, and we're going to talk about all the different ones again and how they independently affect it, like glaucoma and diabetic retinopathy. Figure ground and visual attention. If the patient is unable to pay attention long enough to eat, and pay attention and look, that could be a safety issue. Say if they're like cutting a steak and they're looking and then they don't realize what they're doing, they cut their hand. A lot of different things that go into it. And the next is cognitive impairment, like just attention. Again, paying attention to what they're doing. Memory, remembering how to do it. That they need to open the butter to put on the roll, whatever the task be. Sequencing, that, there's certain steps to eating. You have to put the food on the plate, on the table, those kind of things. And then executive functioning is just more or less making decisions. Go to page 278. Going back real quick to those visual conditions, what are some things that we can do? These are really important to know. I would even want you to copy this page or make a table in Word or whatever and keep this in your phys binder for common OT strategies for self-feeding with these different visual impairments. So cataracts is that cloudy lens. One thing that we do is lower the bright lights. They might need to be in a dimly lit room, which is kind of opposite of what we think, but it's a glare coming off their cataracts is making it harder. And then higher contrast between plate and food. You wouldn't want to put a white plate on this white table or a dark colored plate on that dark brown table. They can't see what is the plate, what is not. Same for utensils. This is where I've been telling you guys all the time about the green is the last color you see. It's not like the last color you see. It's the last color that's recognized and you can contrast is what I meant by that. So you can lay down like a lime green mat on a dark colored table and then put a dark colored plate on the table. And they can contrast that. They can say, oh, this is the plate, that is the table. Same with utensils. Don't use a dark colored spoon or fork on a dark colored table. Likewise, like bright colored silverware on a white table, it's not contrasting. It needs contrast, especially if there's visual stuff going on. All right, diabetic retinopathy, that's the different blind spots. One strategy we use is turn their head to avoid blind spots because they're normally kind of in one spot. So if they kind of turn their head and look at an angle or whichever, that can help. And then again, high contrast plate, cup, napkin, stuff like that. Glaucoma, that's the tunnel vision. That's kind of the loss of the peripheral. One that we do is teach the client to put the same food in the same place. You guys all kind of came up with that one whenever the lab in practice. That was really good. Like the clock method where your meat is at 3 o'clock, your vegetable is at 6 o'clock, those kind of things. That was great. I was really impressed with those interventions. Legally blind. So if someone is legally blind, that is 2200. Perfect is 2020. This is just way off. The clock method is another big one with that because you are literally saying it will always be this way. Now, is the client setting it up in a clock manner? That was one area that kind of got missed when we were talking about interventions. Who are you teaching to set the food up in a clock method? The nurse or the caregiver. Yeah, that's who's setting up the food, not the patient setting it up because they don't know. They're the clock themselves it doesn't mean the same. If they go try to do it, they can't see where they're putting it if it's at 3, 6, or whatever. But if they feel the plate and get to know, this is here, that kind of thing, and they learn that, that's a very effective method. And then macular degeneration. Turn the head to compensate for the blank spots, and then high contrast plate napkin. Okay? Definitely remember that. Highlight that. However you need to keep that in the back of your brain. Definitely keep it for your phys dis binder too. All right, some other things that might affect self-feeding that you might not have thought about is cultural norms. I've run into this several times that some people like to wake up and eat their breakfast at 4 o'clock in the morning, but breakfast isn't served until 7. And they're wondering why the person is mad and not eating at 7. It's because they always ate at 4 o'clock in the morning. Or they only eat 2 meals a day and they're not starving themselves because they'll write down all they refuse to eat, ate 0% and the stuff. And then they're like, oh, they're self-harming. That's not true. It's a cultural norm. It's something they've always been used to and was normal for them. I've ran into that a whole lot. People only eating 2, or they wake up and they're not breakfast people, so they only drink their coffee in the morning. A lot of people do that kind of stuff. Impairments in verbal interaction or communication. Why would that be a big issue with self-eating, Maggie? Mm-hmm. What's really big with self-eating with us? We don't have impairments with self-eating. What's still big with us when we eat? Yeah. Don't ever think this. Even think like toddlers. They're the first people to tell you what when you hand them a plate of food. No. If they don't like it. If you hand somebody who hates peas a plate of peas for dinner and they don't like it, but they can't verbally communicate that to you, whether they've had a stroke and they have these communication issues we're going to talk about in a little bit, it's a huge issue. They're not refusing to eat. They're just not going to eat what they don't like. The same as what we do. We don't eat what we don't like. Impaired pragmatics, that is a different type of language skill. That's changing your language for different situations. I'm going to go into that a little bit deeper in a minute. And then social anxiety or inappropriate behavior. This is really big with stroke patients. You'll have patients that say that they're embarrassed because they go down and they drop food on themselves. They don't want to look like somebody that does that, or a bib. They'll put bibs around them at mealtime, and it's really embarrassing. They don't want anybody to see them that way. It's demeaning to them. What is something that you think OT could do for that? Well, it doesn't. They're dropping it all down themselves. Okay, maybe have them eat in a separate room. What else? What if they don't? They still want to eat with people. They don't want to eat by themselves. What's something that we can do with the bib issue? They don't want to wear a bib. The embarrassing part is dropping the food on themselves. Sitting closer to the table. What else?
What about like a clear thing?
Absolutely. Changing the bib altogether. One of the biggest, or the coolest anyway, OT interventions I've ever seen for this is they made bibs out of normal clothes. So they took button-up shirts or T-shirts and made them look like just normal, but they were bibs, and they just went from like shoulder to torso. And that way they were still kind of dropping it on themselves, but this is used more for patients that didn't want to ruin their clothes. I thought it was a pretty cool intervention. Mm-hmm. Just think of just like a baby bib, but longer. That's what they are. No, I mean, it's just like a baby bib, but it's longer. That's all it is. That's exactly what I mean. Some places do just use towels, but that's demeaning kind of too. Another cool one was long napkins, because that's kind of normal. You see people all the time that'll tuck the napkin in their shirt and stuff like that. That's a little bit more socially acceptable. And they just got really big napkins, and it was like a bib, but it looked like a napkin that was tucked in their shirt and went all the way down. So a lot of people run into those kind of things. They're aware that they look different because they have spilled food down them, or they are wearing a bib at lunchtime. Like people, they get that. I wouldn't want to be one of those people that's wearing a bib. I would want somebody to put that extra effort in to make it look more normal for me. That goes a long way with patients. You can get somebody that's socially isolated into eating and socializing with friends or peers in the nursing home. So what, as far as environment goes, if you're working in the client's home or skilled nursing facility, or even with a client like doing a community thing out at the restaurant, how does OT differ between those two? Or does it differ? Or between those three, sorry.
I'm sure if you're in their home, they're more comfortable.
Okay. And what way?
With wearing a bib or...
Mm-hmm. So they might be more comfortable with that bib idea because there's nobody there to see them other than close family members, and they might not care as much. Okay. What about a skilled nursing facility? Well, how might that differ from what you do? Isaiah?
Your setting.
Mm-hmm.
I feel like that would be the place that you could probably feel the most judgment is public spaces.
I'm going to disagree with you on that because I think that restaurant would be the biggest. I'm going to tell you why is because the people that judge you the most are people that have no idea anything about you. And, you take them to a restaurant, they want to fit in and not stick out at all. So it's trying to get somebody to that stage where you can take them out for lunch or whatever. And that's real stuff. I've done that several times with patients. Gone out for lunch to Bob Evans or something. And, they want to do that. They want to do money management and things like that. That's real world OT. But it's difficult to get them to that point because they are embarrassed of other people seeing them. They've gotten to the point where they're comfortable with their family members saying it. That's fine in the home aspect. But a skilled nursing facility, same thing. They've kind of gotten used to it. There's a lot of people wearing bibs. Okay, it's not that bad if I wear one, that kind of thing. A lot of nursing homes will have separate dining rooms too. They'll have for people that don't need any assistance with eating. They just need their meal served, and they roll in there on their wheelchair or their walker and eat lunch, dinner. And then they have another lunchroom or dining hall that they do have people that need assistance. So they do that for CNA reasons. So that way, while the people that don't need any assistance, they do their own thing. Somebody just has to kind of clean up. But the other hall, there's people that are being messy, people that need help feeding, people that might need help cutting up their stuff, all that. So a lot of nursing homes do have the separate dining halls, which makes it a lot easier for the social anxiety part of it. Why might someone who can self-feed be malnourished or dehydrated? What was one that we talked about earlier? I kind of asked you, Maggie. Why might somebody be malnourished or dehydrated, but they can feed themselves? Communication part of it. Again, the whole, I don't like this, I can't get that through to you, that kind of thing. What else?
Being weak, not being able to.
Okay. Okay. But in this scenario, we're going to say they can feed themselves. There's just other stuff going. Texture, they don't like the texture of stuff. You guys are going to learn all about that Wednesday and today, about different textures of liquids and foods and stuff. What about depression? You know, there's a lot of people that you put them into a skilled nursing facility, they just won't eat because they don't want to be there. They want to be home. Same with the hospital. They'll say, oh, I'm not hungry, oh, I'm not thirsty. And they are. They just don't want to, you know, they have mental stuff going on. Any questions so far, or are we good? All right, let's talk about swallowing. Go to page 283 in your books. The whole aspect of swallowing, what it is, what it looks like. All right, so we need to define something real quick. We're going to talk food now as what's called a bolus. Okay, this is food that has been chewed. It is being prepared with liquids, saliva and whatnot, and it is being prepared for swallow. Okay, so that ball of food that's getting ready to be swallowed is a bolus. So you have 4 different phases when it comes to swallowing. Okay, and if there is a deficit in one of these areas, they will have a deficit in being able to feed themselves. Not the aspect of getting food to their mouth, but then the swallowing portion of it. Okay. First, you have the oral preparatory phase. This is the chewing, getting it ready and turning it into a bolus. The next is the oral transit. This is where it's just above the larynx. It's starting its way down the throat. This is the first part of the actual swallow. C is it's going to the pharyngeal phase. It's just continuing down until it gets to the 4th phase, which is the esophageal phase. And this is where it's going to be traveling down. Okay. They look at these 4 areas when they're saying that somebody is unable to do the act of chewing and swallowing. They're going to look at these 4 areas when they're doing their assessments. There's 2 terms here I want you guys to remember. The first one is dysphagia, D-Y-S-P-H-A-G-I-A, dysphagia. This is an impairment in the ability to swallow. If someone is diagnosed with dysphagia, this is where we change the way that they eat, what they eat, the texture of what they eat in order for them to get nutrition. The next term I want you guys to know is aspiration, A-S-P-I-R-A-T-I-O-N. This is where you get penetration into the airway with food. So food has entered the airway or liquids. There is such a thing that is called silent aspiration. You know, normally if we get something in our airway, we're like, but some people will swallow just a very small amount and it'll get into their airway, just a tiny amount, and eventually it will build up and aspirate and cause pneumonia, and that is really, really hard to get. That's a silent aspirator, and I'm going to tell you how you would know or see those kind of things. A lot of people, when they get older, do silent aspirate because their muscles and things get weaker. Have you guys ever been in a therapy clinic with speech therapy and you have or see them hollering out K, 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 or like different vowels? It's something cool to see when you go in your field works. It's helping. There's certain letters that we say in the English language and alphabet that help strengthen certain muscles. It's kind of awesome. I think it's so cool. I love speech therapy. I think speech therapy relates to OT so much. And I worked alongside speech therapy almost more than PT in my practice so far. But it's pretty cool to watch that. There's a lot of different things that they do to help strengthen those muscles. But just be aware that if somebody is, it doesn't take somebody going, to see that they're aspirating food. It could be something very, very small, and it just builds up over time until they reach a level of pneumonia. Go to page 283 again, that table right there. There's two different types of dysphagia. You have the oral or pharyngeal dysphagia. This is where they might have difficulty with chewing, or it takes them a long time to chew, something that shouldn't take a long time to chew. Leakage of food or liquids from the mouth. That's another big one. They keep it in there and they don't really know it's there, and it's kind of dripping out the side. Drooling, coughing, choking, delayed swallow initiation, just being able to initiate a swallow. Weight loss, change in dietary habits, nasal drainage, watery eyes, wet and gurgly voice. Have you guys ever heard an old person have that? Like a wet, it just sounds like they need to clear their throat. That is extreme, and that's a huge sign of dysphagia. Again, the penetration or aspiration, and then aspiration pneumonia is another one. And then esophageal dysphagia is regurgitation. They might, get it down and then it wants to come back up. Sensation of food sticking in their chest. Like they could say, oh, it feels like that hamburger after lunch is just sitting right here, which is not uncommon for people to say. Unexplained weight loss, and then recurrent pneumonia. These are all signs and symptoms. Again, this is another table I want you guys to keep in your PhysDis binders. This is safety stuff, and you can really save somebody a huge, long hospital stay over just early identification. Okay? Very important stuff to know, and there's lots of questions on your exam about these. Okay? Cool. I think I did. Yeah. All right, so evaluation of swallowing and dysphagia. There's different types of tests and different types of examinations and evaluations that they do for swallowing. These are not done by us, okay? But we may have, recommend to a nurse or to the speech therapist, hey, they might need a swallow study. I noticed this was going on at lunchtime. Oh, yeah, I'll evaluate them, and that way you get that early identification. Just because we're not directly doing these, you need to be aware of what they are, how they're scored, stuff like that. All right, so on page 285, they're listed there. You have the BSSE. This is the bedside swallow examination. This is where they go through different textures. They assess their coordination and their strength. They add that in. And they teach comp strategies. And will teach comp strategies. This is basically going in and watching them eat, more or less, different types of textures. The speech therapist will go in and watch, majority of the time, a speech therapist will go in and watch them actually eat something, see if they're, coughing, see if something like that is going on, see if they need a swallow study. An MBSS is the modified barium swallow study. This is where they actually watch them eat a cracker and drink water on an x-ray to see if it does go down and they aspirate it. It's pretty cool. You guys can look that up on YouTube. They watch a video of it. It's pretty neat. I mean, you get to watch it go all the way through, and you can see difference of what does it look like if they aspirate, where does it go, those kind of things. The FEES, that's the fiber optic endoscopic evaluation of swallowing. That is where they run a tube up their nose and a camera and then watch the pharyngeal phase of swallowing. I just think that just sounds so awful. I wouldn't want anything to do that, but it's part of it. I thought there was, the video, I can never pronounce this one, video fluoroscopic, hey, I got it that time, swallowing study. That is the MBSS. So if you hear it called that, the modified barium swallow study, that is the same thing. Okay? Cool. You guys know those? Back of your hand? Cool.
The video is the same as the modified barium?
Yep, it's the same thing. It's just commonly known as the modified barium. Not about barium, not about barium. All right, so then you have presbyphagia. This is age-related changes in swallowing. This is the weak muscles, whether in their jaw or their throat. This is where they might even do E-stim on the patient's throat. It takes a special certification with a speech therapist to do this, but they'll put those electrodes that you guys did the TENS unit with, that they'll do with an E-stim machine and actually like kind of shock those muscles to help give contractions, help build strength, coordination, stuff like that. They're at high risk for choking here because they can't quite get the food down or they can't chew it accurately. What is one thing right off the bat that we could tell a patient to do as far as OT goes if they have presbyphagia? There's a problem of like chewing and muscle strength. Huh?
Chew gum.
That's an interesting one. Nobody's ever said that.
I
Yeah.
was thinking that too.
Chew gum. Maybe. What else? Don't ever think this. Cut your food up smaller bites. Absolutely. What about chewing more? Don't chew so fast. Chew it more. Make sure you really chew your food up. Be aware of you eating. Don't let it be a mindless activity. I mean, how many of us, when you're sitting and eating, you're mindless of you don't know how many times you're chewing? Neither do they. But teaching them like, okay, you need to make sure this is good and ground up before you go for a swallow because you can choke. And watching them eat and making sure they're doing that and training them on that. It is absolutely an OT intervention. You might have somebody for an hour and you go sit with them at lunch and watch them eat. That's an OT intervention to make sure that they don't need any utensils for self-feeding. I mean, that's the basic of basic ADLs is you have to eat. So we're, really through that process all the way. We're going to talk a little bit about diet modifications. You guys are going to get to see these. Yes, you're going to try all the different types of liquids and what they're like on Wednesday. The different thickness of it. We're going to thicken coffee. I think we thicken coffee, pop, water, and so that way you can see the different consistencies. They're not popular, and it doesn't change the taste of it. It just changes the texture of it.
Are you adding powder to it, like jelly powder?
It is. You add, it's almost like cornstarch to it, and there's different thicknesses, and different places do it different. If you're really good, you can eyeball measure it. And a lot of speech therapists, older speech therapists, that's all they ever had, so they do it that way. Nowadays, and what we're going to do, it comes in packets, and it says for 8 ounces of fluid, add this whole packet to it, stir it up, and then it's into this thickness. Okay? All right, so as far as liquids go, first you have thin liquids. That's just your normal water. That's your normal thing. Okay? Next is nectar thick. Does anybody know what nectar is? Yeah? It's kind of like, think of hummingbird nectar, that kind of stuff. That is the consistency that they go for. That's the next step. If they have a little bit of an issue, but not much, they need a little bit of help, that's what they go for. Then next is honey thick liquid. You think how thick honey is and how, I mean, you can thicken anything. I've thickened a beer for somebody. Milk is disgusting, but what else? But chocolate milk. Chocolate milk's not bad because it kind of turns it into almost pudding. Well, the next one is pudding thick liquid, and you do chocolate milk that way. It's chocolate pudding. It's interesting. It's different than what you think it is, and I really like doing that. We'll do that on Wednesday.
Which one is this?
What?
The thickness type. Which one is this?
Which one is what?
The third one you just said.
Honey. And then pudding is next. Pudding thick. Okay? Faith is not having this.
I don't think this sounds very nice either.
It's not. Well, I mean, I think it's interesting. Listen, if somebody in your life or your patients have to eat that every single day of their life, they're not allowed to have anything other than that. I mean, 1 spoonful of a honey thick liquid, for you to understand, is pretty beneficial.
Is it going to taste like honey?
Well, don't throw up. No, it doesn't taste like honey. It's the thickness of honey. It doesn't change the flavor of anything. It's only the texture. Okay?
I remember right before my grandfather passed, he was it wasn't hospice, and he was eating pureed food, and they were literally giving him like Thanksgiving meal puree, like
Yep.
mashed potatoes and turkeys.
Yep.
Like that he would drink, and it was just so sad.
I don't know what foods she is doing because this is Professor Charlie. This is a 209 thing. She does some of the foods too. I don't know what one she does. I can't remember, but she does do some of it. I don't know what she does. I can't remember. But they do legitimately. It sounds awful, and I wouldn't like it either. But think about these patients. This is what I'm telling you, that it's so important to know and understand is people aren't just refusing to eat because they want to. They're refusing it because who wants a blended hamburger for lunch?
Yeah.
But that's all they can have. It sucks, but that is the nature of it. There are different textures as far as food goes too. You have regular solids. That is all foods, no food restriction at all. Regular chopped foods, that is where their meats have to be chopped into small, bite-sized pieces. For example, chicken needs to be cut into small cubes, sausage chopped up into small bites, stuff like that. Mechanical soft, this is where they have ground, moist, semi-soft texture. For example, ground beef or ground turkey with gravy on top. So they don't just have the meat portion. They add like a liquidy kind of stuff like gravy on top of it. And then you have the puree solids. That is exactly what you think it is what they turn whatever it is into like a pudding thick liquid. And that sucks. Again, it doesn't change the taste. A hamburger blended up still tastes like a hamburger, but it does. It still tastes like a hamburger, the texture.
Give them like smoothies or things like that, like protein milkshakes.
But that's a thin liquid. Same thing like ice cream. Everybody says, oh, you can give them ice cream. No, you can't. It goes in their mouth. It turns into a thin liquid. It turns into milk. One thing that doesn't is Jell-O. Ice cream? You have to melt it. Yeah. Well, then you might as well just thicken milk and put sugar in it. Some is, and you have to play with it. I mean, nobody wants that, but I'm just trying to put this in perspective. It's not fun. It's not fun for you guys. It's definitely not fun for your patients because that's all they can have for every meal for a long time until they can pass their dysphagia screenings, those tests that we talked about. Yeah, that's what a milkshake is. It's milk and sugar. I mean, some of them they have strawberry or flavoring in it, but that's all like a vanilla milkshake, or you could have vanilla in it. That's all a milkshake is. Well, yeah, but with milk.
I know, it's just weird. It's weird to think
ice cream is milk.
Yeah, but like, I don't know.
It's all the same. We've been lied to.
You just go from milk to a milkshake. You have to go from ice cream to a milkshake.
It was just, it's probably what I just had on hand or what the facility had. All right, let's get back on track. Another abbreviation that is really, really important to know is NPO. NPO. That means nothing by mouth.
Nothing by mouth?
I don't know why it's NPO, but it's called nothing by mouth.
Why would they do that?
Very important to know. That will absolutely lose your license. That will get you sued, and that will lose your job in a heartbeat. If you give somebody that is NPO something to eat or something to drink, that can kill them. It's a literal life or death thing that you know this. NPO. This is being aware. Now, it's not, some facilities have different rules. Some of them put a sign above their bed that'll say NPO. Some facilities think that's demeaning, and they say, look in their chart. I think it's way better to put it on the sign. I think I think safety outweighs it there, but sometimes. Now, you think this is easy, but it's not. You get this little lady who you can see is malnourished and hasn't had a whole lot to eat, and then she rolls up to you in your wheelchair, and she asks you for a little Debbie cake out of the therapy labs or the therapy gym's cabinet. You want to give it to her. You don't know she's NPO. You give it to her. Your license is gone. Your job is gone, and you're kicked out of a job. This is instant stuff. This is not. Another thing is a lot of therapy gyms have water coolers in them, and these patients are desperate. Think if I told you you can't eat or drink anything. These people that are NPO have feeding tubes. So I'm telling you, you can't eat or drink anything, period. I'm going to feed you and give you nourishment through this tube. And then you're going to be looking for something to eat too, right? Eventually, you're going to rebel. And almost all of them do if they have physical capability to get out of bed or roll around their wheelchair. They really want something just to take think about how dry your mouth would get in oral hygiene. Literally nothing by mouth.
Their teeth.
A lot of the times they get really bad dry. They can brush their teeth, but they can't swallow anything. When it says nothing by mouth, they can't swallow anything. That's what I was getting ready to do. Tell you is you can do. It's a little sponge thing. It goes on a stick, and sometimes they're flavored, like lemon or something, a strong flavor, and you just barely wet it down and get it damp, and they'll just go across in their mouth and tap. It's so sad, but I mean, you're talking. These people are miserable. Oh yeah, oh yeah. Done that.
Vitamix? You get a Vitamix through insurance or something?
It just depends.
What if they only get like a Black & Decker from like Walmart and like it's not good enough?
Like, are you talking about like just throwing it in a blender?
Yeah.
I mean, you have to have the right texture. And most of the time, that comes from the kitchen. It'll tell them, and it'll say on their tray, pureed solids, pudding thick liquids or whatever on their. They get a lunch ticket in the long-term care, and it'll say that on their lunch ticket. And these people are sneaky as all get out. I never, and that's a good rule of thumb, and I want you guys to remember this as long as you're practicing. Don't ever give a patient food without checking their chart. Ever. No matter how bad you feel for them, no matter how much of a puppy dog face they give you, do not give them anything to eat. Do not give them anything to drink until you are 100% sure you are giving them something safe, because you literally can kill them. Okay? Cool? That was almost as stern as a Director Hurt email. All right. All right, so compensation strategies and precautions, things that we do. Environmental modifications. Again, if they want to eat alone, that's fine. If they don't want to eat alone, that's fine. We need to find a way to modify their environment the best we can, so that way they feel comfortable and are safe eating. Positioning. You don't want someone laying down. I don't know how many times I've walked into a room and a patient's laying on their side trying to eat their tray because the CNA didn't take the time to raise them up. I'm not talking crap about CNAs. They're overworked, but it's the nature of the beast. So positioning is huge. We're going to talk about that over here Wednesday. The pace of the meal. Tell them, take your time, small bites, chew it a lot. We're trying to keep you from having to have a feeding tube or having to go on honey thick liquids. Show them what that looks like if you need to. Like, this is what you will have if you don't start listening. Those kind of things. Food temperature. Nobody likes, how many times have you got something cold from a restaurant and you're like, this is gross, like I don't even want to eat this. Same thing with these people. Just because, I know this sounds nasty too, just that they get a pureed hamburger doesn't mean they want a cold pureed hamburger. That even makes it worse. So sometimes it's just heating it up makes a big difference for people. The amount of food. You don't want to give them a whole lot and you don't want to give them too little. You want to kind of space this out with people, learn your patients. Inhibition of primitive chewing patterns and reflexes. That's more stuff we're going to talk about in pediatric and what to look like in adults. We'll talk about those a lot in spring semester. Alternating swallowing or techniques or positions. If they have poor jaw strength, and that's something, you might have them chew one bite on the left side, switch and do the next bite, chew it on the right side and alternate sides so you don't get too worn out. This stuff sounds like it's silly and simple, but these are huge fixes that make a difference and will keep people from, going down the list all the way down to feeding tubes. Oral hygiene is huge. If they're not brushing their teeth are rotting out, that's clearly a feeding issue, right? Making sure that they know that is a big deal. Making sure they're taking care of their dentures so their gums don't get inflamed and bacteria build up, all that stuff. And then E-stim. Again, I've never seen an OT or OTA do that. I'm not going to speak to it if it is in our scope of practice because I've never seen anyone do it. I'm not 100% sure. I've only seen speech therapists do it, and they have to have a special certification to do that. So I'm not really sure if that's in our scope or not. I could ask Dr. Brown if she's ever done it, or if it is in our scope, she probably wouldn't Do you guys need a break? We're only got about 4 slides left, but are we good? Kind of moving into a little bit of a different topic. Still in the same chapter though. Communication. I want you to give me an example, Maggie, of verbal communication. Great. Allie, give me an example of written communication. While she's coming up with that, Jennifer, give me an example of nonverbal communication. Great. Facial expressions. Very good. What about, you guys don't know these yet, so receptive communication. Anybody read ahead in this chapter? Anybody want to be like, yeah, I did? Yeah, you did? Oh, you're looking at it right now. That's comprehension, or the ability to understand language. So this is receptive communication. That's another form that we're going to talk about it. It's really just understanding what is being said, okay? Being able to understand and stay on track with our conversation. Expressive communication, this is your thoughts, ideas, or concerns about who the communication is intended for. This is you being able to say, you know, this is the way I feel about it. I am stressed that our documentation assignment is due today. I'm not ready for it. That's expressive. And then pragmatic, again, this is situational communication. It's verbals and nonverbals that govern communication. That's a fancy way of saying, like, you change your level of communication for the situation that you're in. I'm up here lecturing to you guys now. I have a certain type of communication. I'm a little bit louder. I try to explain things a little bit more. I have a totally different type of communication if I'm sitting at a buddy's house on Friday nights playing cards. It's totally different, right? We change our communication. That's pragmatic communication, being able to switch back and forth between situations effectively, okay? Because some people, when they have strokes and TBIs and stuff, they can't do that. They don't have their inside voice that we like to think about, which makes it very difficult at self-feeding time. Some of the impairments as far as communication goes, a hearing impairment like being deaf, that really does affect it, because the world is starting to become very adapted for the deaf community. You hear a lot, most drive-thrus now have adaptations to menus and stuff. It's pretty cool, I think. Yeah, most, if you ask, pay attention next time you get to like a McDonald's drive-thru or Wendy's or whatever. It's normally a sticker located on the window at the drive-thru that'll say, you know, impaired menus are available, or whichever, like hand menu, so they can point to what they want, stuff like that. It's pretty cool.
Taco Bell, they have like the order yourself tablets. Oh yeah.
Yeah, which is really cool, like the self-ordering things now, because like no communication really has to happen at all. It's more of a, you know, thing. No training, extra training has to be done. If they have a speech disorder, and I'm going to show you guys a couple of these, what they look like today. One of them is expressive aphasia. This is a deficit in being able to communicate your thoughts, emotions, and ideas. The next one is receptive aphasia. This is the exact kind of the second part of it, is comprehending the information. So expressive aphasia is not being able to communicate your thoughts. Receptive aphasia is not being able to comprehend new information, like when someone's talking to you. Okay? Next is dysarthria. Dysarthria is a motor speech impairment. This is literally motor stuff going on, like you're not able to mouth out your words correctly. It could be a speech issue from strength of your vocal cords, all that stuff. I'm going to show you what that looks like in a video in a minute. And then apraxia. This is very, very, very similar to dysarthria. Most of the time it is actually diagnosed as apraxia, but it is caused strictly from brain injury. Could be a stroke, could be TBI, stuff like that. Okay? All right, so what are some of our strategies? How can we modify the environment for somebody that has a communication deficit? Lindsay. Communication, and we're going to stay in the context of self-feeding. somebody has a communication deficit, any of those that I just listed on the last slide, how can we modify the environment for these people? That was awesome. That's kind of what I was hoping you'd say. Does anybody know what a communication board is, other than knowing it's called a communication board? Yep, there's all kinds of different kinds. Depending on,
Over there.
I don't know. I don't know. You have to show me, and I'll tell you if it is.
Yeah.
No, that's an orientation board. That's an orientation board. That's a little different. We use those for dementia a lot. But what was that? Our communication board is kind of pictures. You can get them a board that literally has like a picture of food, and they hit it. Could be something they can type out. Because sometimes, a lot of the time, somebody might not have it. Depends on what is going on with them. They might not be able to verbally say it to you or non-verbally even say it to you, but type it on a computer and say it. It could be anything like that. An AAC is an augmentative and alternative communication. That could be either low tech or high tech. That is any form. That's the official way we talk about any form of communication other than speaking. Like the nonverbal stuff. Anything that we add, like communication board, iPads are huge now. A lot of people, even they'll pull out their cell phone and use that to help. Some are a little more difficult to treat than others. It depends on what is going on. So. All right, so what would be our role in using that? Don't overthink this. This is a simple question. Education, teaching them how to use it would be huge. Teaching them the appropriate times to use it, those kind of things. I have seen Bunny the dog on TikTok.
The one that
He uses an AAC. Yeah, he hits the buttons. It is a doodle. Yeah. All right, guys. Any questions? Are we good? All right, you have 2 knowledge assessment questions tonight. They will be due tonight at midnight. And this is your last knowledge assessment for the semester. Yay! We're not doing it as a group. By the end of the chapter, you should be able to answer the following question. A client with finger flexion contractures caused by rheumatoid arthritis is having difficulty feeding herself. The OTA student recommended a built-up handle for the spoon. Why is that not appropriate? Okay. I'm not telling you what the answer is. All right, and this is a multi-select, okay? This is one of the first. Now, these types of questions, I know you're going to hate me. These type of questions will be showing up on exams for spring semester because these type of questions are on your board exam. They're called multi-selects. What sucks is if you don't get all 3 answers, the whole question is wrong. I'm going to do that for my exams because that's the same way your board exams are. If you don't get all 3 of them, the whole question is marked wrong. Okay? I hate it, but I'm trying to prepare you for it. That's my goal. That's my job, to get you ready. So that's what I'm going to do. All right, so a client with a brain injury is having difficulty following his swallowing precautions. He needs constant cueing to swallow before putting more food in his mouth, and he yells and throws his utensils at other clients. Which 3 techniques might the OTA teach the caregiver to use with him? Okay, and again, you have to get all 3 of them, or the whole question is wrong. Yep. I'm sorry. Hang on. I'll show you guys a couple videos.